All right, hello everybody. This is the update for the 2025 stability chart for C3IFT. This is the new layout of the stability chart. It's just been reformatted to look similar to the most current version of the protocols, where it has the name of the protocol to the right, the heading is different to match, and then there have been a few things updated within that stability chart of what the C3 provider is able to transport or what must be upgraded to CCT. So it changes again. The look is one big update just to match the current protocol format. And as it was before, on that stability chart, if you answer yes to any of the questions, that must upgrade that transport to a CCT or up to a level 0. It's updated to match the changes in how the protocol numbers are listed and the identification of what that protocol is to the right side. Some updated information. There's going to be a little bit more information contained in that regarding a level 0 transport. Remember that level 0, that means that the hospital has taken 100% liability for that transport, and they will be sending personnel from the hospital. So from the sending facility, they will send their own personnel with that crew to be able to take that transfer to the receiving hospital. Again, sole responsibility lies on that referring or the sending hospital. The referring hospital, again, is going to provide everything. They're handling it all with all the medications, the personnel, the equipment, everything that is needed. There must be some mechanism for that accompanying hospital providers to reach the referring position. So that's where EMS would come into play, is they will be basically giving the transportation vehicle for those providers to be able to continue care to the hospital. And again, that at that level 0, that sending facility must maintain patient care until full reports given and the receiving team, the receiving facility acknowledges receipt of the patient and they have completely assumed care. On that C3 exclusion list, it is now only nitroprusside or phenobarbital. Neosynephrine has been removed, so the C3 provider can now transport neosynephrine. The modalities remain the same. If there are more than 3 of these, then it is CCT. Each one of these being considered one modality. So if they're on a medicated drip, each medicated drip is one modality. Blood product, chest tubes, CPAP or BiPAP, and ventilator. So if you had a patient on a ventilator and they are on 3 medicated drips, that would be 4 modalities, and that would be required to be a CCT transport. With the vital signs, so if the MAP is less than 65, that's a CCT transport. If the MAP has been greater than 65 for less than 30 minutes, so just an acute MAP, they finally got the pressure up to above 65 in a brief moment, they want it to go right now, it needs to be CCT. But again, if they just got to that point, by the time you're getting paperwork done and everything else, hopefully that MAP would sustain at 30 minutes. A sustained heart rate greater than 150 doesn't mean intermittent occurrences, that is just where their heart rate's at. In that adult patient, you can't get that heart rate less than 150. A sustained respiratory rate greater than 28. So if they're in some metabolic condition and they're compensating and they're breathing greater than 28 times a minute, that would be CCT. Or sustained hypoxia less than 88%. And from before, the thing that changed in that vital sign part of it was that increased heart rate used to be 130, and now it's been upgraded to 150. If there's any consideration that this patient needs DAI or RSI throughout that transport, again, that's going to be CCT, having that capability to intubate en route. Now, if you do think that that patient would require that drug-assisted intubation, that is a big fear, talk to the sending physician on just performing that procedure before you go and transport. The only thing to consider there is if that would change and increase that modality, again, being more than 3 of those modalities. With drips, 2 vasopressor drips is CCT, or 1 vasopressor and one of the following. So if they are on a pressor and are intubated, that requires CCT. Vasopressor and an insulin drip, CCT. Vasopressor and an inotropic drip is CCT. So what did change in that was before, if it was a continuous sedated patient that would require 2 C3 providers in the back, that has been taken out. But it still remains, if that patient is intubated, there needs to be the C3 provider and at least an EMT accompanying them in the patient compartment the whole time. Also, removal of that continuous sedation drip. So that patient can be receiving those continuous sedation drips while they're on the vent and still be C3, again, as long as it stays within those modalities. Another thing in the drips that was removed was the antiarrhythmic drip. So before, if that was 1 vasopressor and an antiarrhythmic drip, that was taken. This has now been taken out. For the pH, this was always a big one. Before, it was always listed any patient with a pH less than 7.2 required CCT. What that's been changed to now is specifically for DKA patients. So if that DKA patient has a pH less than 7.2, that's not including administration of sodium bicarb. So if they're in DKA, have pH is less than 7.2, and they have not received bicarb, that is going to be a CCT transport. But again, DKA patient, sustained pH less than 7.2, that's going to be your CCT. If they're going to need any re-administration of blood products, because standard C3 transports don't have the ability to carry and maintain adequately the blood products. So if there's going to be re-administration en route, that is a CCT transport. Intubated and on insulin drips. Again, that little part was updated to remove that continuous IV sedation, because we all know it's much better and safer for the patient to be transporting them with those continuous infusions of sedatives rather than to just be doing pushes PRN. On the stability chart, this has remained the same. If it's a pediatric patient on an insulin drip, CCT. If it's a pediatric on a vasopressor, that is CCT. In the written documentation, this has been added to the bottom saying the referring physician, that sending physician, shall, meaning that they 100% have to, provide EMS with written documentation of all patient care orders anticipated during the transport, whether that's paper or electronic. So that must be a written order, basically giving you the protocol of how to take care of that patient during the transport, what parameters, if medication could be titrated, how much, when, what the indications for those are. Basically a whole instruction manual for that patient, that those shall accompany the patient. Any unanticipated orders. So if EMS, excluding class 0, because that's hospital medical staff handling the class 0, requires unanticipated orders, medical command can be contacted. Okay, this is as a guidance for incidents requiring those unanticipated orders during transport. So something came up that just kind of went awry, you can contact medical command. So to highlight the changes, neosynephrine has been removed, so you can transport a patient on a neosynephrine. That increased heart rate threshold has changed from 130 to 150. And that removes that 2 C3 provider on that intubated patient with those continuous sedatives. And removing that continuous sedative drip exclusion, also removal of that antiarrhythmic drip. So then it's kind of reducing the number of modalities with the removal of those. So here's the cross comparison between the old, which is on the left, and the new that's on the right. So you can see the style formatting has changed. Okay, and again at the top on the new one, answering yes to any of these questions mean it's a CCT or a class 0. Again, emphasizes on there again on what that class 0 is. So if we start at the C3IFT exclusion list, now you only see nitroprusside and phenobarbital. On the old one, you would see that neosynephrine was on there. That has been removed. On the modality list, that has remained the same. Formatting just changed a little bit. For the vital signs, that is all maintains the same with the exception of that sustained heart rate going from 130 to 150. But pulse oximetry less than 88% or tachypnea greater than 28 a minute. Does the patient have high risk requiring DAI or RSI? That is on the left, and it's been moved a little bit to the right. Now you see below the pH. I'm sorry, actually that part is not there listed on that. But DAI, if that is required, that's going to be CCT. So as a C3 provider, you cannot be given orders to do RSI. Is the big takeaway on that. So is the patient on 2 vasopressor drips and or a vasopressor in one of the following? So before, you could see that it was continuous sedation drip. That is now out, and the antiarrhythmic drip has been taken out. So 2 vasopressors or a vasopressor and an insulin drip, or vasopressor and an inotropic drip requires C3. Okay, now the other little bullet that's added on the new one: for intubated patients on a single vasopressor, stable for more than 30 minutes without titration, can be handled by the C3 provider. Again, as long as there's at least an EMT provider in a patient compartment at all times. So just remember, if they've been put on that vasopressor, they have to be stable for 30 minutes per that stability chart. The pH has been changed to specifically say DKA patient with a pH less than 7.2, not including administration of sodium bicarb. Does the patient require more blood? If that is a yes, CCT, same as it was before. If it is intubated and on an insulin drip and on an inotropic drip, then that is CCT. Just as it was before, a little bit of formatting changes. And again, is a pediatric patient on insulin drip or a pressor? If yes, CCT, same as it was on the last one. And then you see at the bottom there the blue box: the referring physician shall provide EMS with written documentation of all patient care orders. That has been added in there, as well as that if EMS, excluding class 0, requires unanticipated orders, while you're en route, something came up that wasn't on your written orders, contact medical command.